Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing a case of an elderly male who presented to our ER with complaints of breathing difficulty along with productive cough. So, sir, there was a 68-year-old male patient who was a known case of COPD, presented to us with complaints of progressively worsening breathing difficulty associated with productive cough.
Okay.
So, in our initial 10-second assessment, patient was conscious, oriented, obeying to our commands. Primary survey-wise, airway appeared patent. Air entry was there was no excessive pooling of secretions, no hoarseness of voice noted, and then moving on to the breathing wise, patient had air entry to be bilaterally equal, but there was profound wheezing with bilateral creps heard. Saturation was only 84% on room air. Along with this, he was tachypneic with respiratory distress signs seen, like usage of accessory muscles were there, and respiratory rate was 36 cycles per minute. At this point in time, our intervention was to, since he was a COPD patient, we had to give a controlled oxygen, but our target was to maintain above 88%. But in view of increased tachypneic work of breathing, we planned to provide this patient with positive pressure ventilation and had arranged for a BiPAP. So circulation wise, he had a normal heart rate of 88 beats per minute with a blood pressure of 130/70. All peripheral pulses were palpable. Disability wise, his GCS was full score of E4 V5 M6 and pupils were 2.5 millimeters, bilaterally reactive to light. And exposure wise, he had a normal body temperature with the blood sugar levels of 115 milligram per deciliter. And as our adjunct, we used an ABG and it showed type 2 respiratory failure with a pH of 7.1 and a PCO2 of 67.9 with a PO2 of 55 and a SO2 of 83.3 with a bicarb of 24.2. Lactate, on the other hand, was only 2.1.
Yes.
So we initiated the patient on BiPAP as the patient was conscious, oriented, and also obeying to our commands. He was cooperative, so we placed him on BiPAP and further moved on to our survey. Moving on to the secondary survey.
We'll just wait here. So we have an 60-year-old. What was the age of
68,
the 68-year-old gentleman coming with history of breathlessness.
Yes.
So there was associated fever and cough.
There
was associated fever and cough, and he's a known COPD. So on this background, you have received this patient, and we examined the patient, and there was minimal hypoxia initially.
Yes,
so initiated him on NIV. So which all patients you wanted to put the patient on an NIV? So what is the ideal?
So NIV is basically, you will have, it's a positive pressure ventilation. So the patient who is conscious, oriented and obeying to our commands. Okay. Indications would be when the patient has acute respiratory distress, like increased work of breathing, like in cases of pulmonary edema or pneumonia, or if patient has type 2 respiratory failure, like in cases of this COPD patient, or acute exacerbation of bronchial asthma. So wherever patient has usage of accessory, increased tachypnea is there, and then we'll initiate the patient on BiPAP.
So as of now, you have to be very specific. The classical indication when the CPAP or BiPAP was started, the classical indication was for two things: acute cardiogenic pulmonary edema, and it was for acute exacerbation of COPD. These were the two things that they found, okay, this is definitely going to help. But later on, you had COVID. So COVID coming in. So we were using it before also for acute lung injury and early ARDS, pneumonias and all. Definitely it was helping in. So and even for patient with metabolic acidosis. So metabolic acidosis, again, there was a lot of carbon dioxide washout. So as a result, the respiratory rate was high. So in order to decrease their respiratory effort, we used to keep them till maybe bridging for dialysis or all those things. So NIV as a whole thing has come up a lot as compared 10 years back. 10 years back, this was the only two indication, but now almost every patient, if it is not contraindicated, we can start on a non-invasive ventilation. So let's see which all patient you should not start. Okay, this patient is not an ideal candidate for non-invasive ventilation.
Sir, in that case, when the patient's GCS is less, like less than 13, is not cooperating, and we know that the patient and the BiPAP machine will
So you
have
can say
dysynchrony.
definitely contraindication will be less than 8 GCS. Less than 8 or the patient is in cardiorespiratory arrest. Definitely you will not be able to put the patient on an NIV. So that will be the one. Then the next thing is, as the GCS comes down, there is always a chance of failure rate of NIV to be high. So you see a patient with a COPD coming with an 80 PCO2. Now this patient has come, the saturation is around 70-75%. Now again, when you are connecting to the BiPAP, your GCS may be like something like 10 or 11. That might be attributed to this excess CO2. But those group of patients, they might come out. But as the common predictor for an NIV failure, you have to have the classical Hakor score, where the sensorium is low, the GCS is low, the chance of failure for NIV is high. So this is one thing that the low GCS is definitely not an indication, but maybe a borderline GCS of 11, 12 and all, we can try with NIV if you feel that the primary issue is with carbon dioxide retention. So the next,
Mask seal.
Mask seal. If those who can't provide a mask seal, a pregnant lady, it's again NIV is going to be a difficulty. Then you are suspecting a GI perforation. So you are suspecting a perforation. So again you are going to inflate some aerophagy is also going to happen. So definitely you will not start NIV. Then other contraindication might be an severe hypotension. Yeah, maybe a septic shock, borderline septic shock with noradrenaline, we might be able to put a patient on NIV. But as you put a positive pressure ventilation, again the intrathoracic pressure increases and venous return decrease. So hypotension chances are high. So this will be the definitive contraindication, and also when you are suspecting a pneumothorax. So we will not put NIV for non-invasive ventilation. What I mean here is BiPAP. BiPAP or CPAP. I am not speaking in terms of a high flow nasal cannula. We are just focusing on a pressured mechanism by which the breath is being delivered. So what the basic difference between a CPAP and a BiPAP?
So in CPAP, there's only one component wherein basically this is continuous positive airway pressure. This is constant PEEP. Whereas in BiPAP, there are two levels. There's two components like inspiratory pressure and an expiratory pressure, which is equivalent to PEEP. So the
expiratory pressure is equivalent to PEEP.
PEEP. EPAP and IPAP are the two components of BiPAP. So only patients who will require PEEP, like in OSA patients, wherever inspiration patient is able to take, but expiration is a problem, then that patients will keep the patient on CPAP. Whereas in BiPAP, where the patient has increased work of breathing, tachypnea is there, and patient will require inspiratory pressure to open up the alveoli also. In that case, we go for BiPAP. Okay.
So what you have to basically need to understand is that in CPAP, there is no cycling. In BiPAP, there is cycling. So there is an inspiratory and expiratory separate pressures we are keeping, and the machine itself know when to give the breath during the pressures during the inspiratory cycle. So again in BiPAP we have two modes. You have a plain NIV mode and we have something called as an ST mode. ST mode we are fixing at a specific respiratory rate. Suppose you wanted the patient to take minimum of 16 breaths per minute. You can put the patient on ST mode, but patient might have some difficulty in tolerating that. But in the normal NIV mode, we are just supporting his normal inspiration and expiration. So that is the only thing that is basically different. So one thing that you have to be very specific, you have to make sure that there is no contraindication for starting an NIV. Basically, any respiratory distress, we can put the patient on NIV as if now. But you have to be very specific, there is no contraindication in terms of whatever we have discussed.